So good morning. Today we're going to talk about which states are doing enough COVID-19 tests. And again, this is to help support the activity of getting us back into the workspace, back into our society. Before we go into that, I'm going to ask, did I ever mention that I hate technology? So Joe Riley and some others asked that we set up some sort of delay after going live because they have commercials for about a minute. So Carl set that up. We did have that music, that background music, and it was just sounded really good until you put it on this, and it was like really awful. Meanwhile, as I've complained many times before, you've got multiple pieces of software working here. You've got YouTube, and it's different pieces of software broadcasting things, but we've got to get our own thing going. We've got a screencast where we're taking our screen, my computer screen, and broadcasting it while it's taking an image of me from the camera. And between that camera and YouTube, there's a mini USB port, a mini USB port cable, an Elgato, 2 dongles, and then the USB-C. And it's like, we shut down the computer and the camera, gosh, this morning. Just before this video, we did it like 3 or 4 times. Prior to that, I had done it like 9 times because I kept coming out really green. You know what? It would be nice to be able to go back and review the content before you do these things. But thank you very much for listening to me whine this morning. Again, the topic for today is COVID-19 testing. Who's doing enough of it? We'll get into a little bit more detail on that in just a few minutes. Before we do, upcoming topics, race to a vaccine. A lot of interesting types of vaccine, and we're going to show some great graphics that show you all the different ways that you can build a vaccine. You can build a vaccine which tells the cell to just using genetics, and I think that's is it Moderna? There's a totally new vaccine company that's coming out with this, and they're using RNA, I believe, to go ahead and just go into the cell, redirect the genetic materials of the cell to start making the antibody proteins to that cell. Other types of vaccine, the old style vaccine was where you'd get pieces of the protein, like pieces of the protein shell of a virus, and you'd put that, you'd grow multiples of that in another, in something else, like a bacteria. You'd insert it into the genetics of the bacteria. Then take that protein and inject it into people. Then our immune system recognizes that protein itself. I'm getting kind of deep into that. I'll leave it alone. Bottom line is there's a lot of ways to develop a vaccine which creates immunity. Now, next topics, new condition in children. You know, we've talked multiple times, starting with that original New England Journal article that I covered, gosh, over a month ago. And it looked at like 1,200 kids, and it said, you know, out of 1,200 kids, we had 3 deaths with coronavirus. And they were with coronavirus, not due to coronavirus. You know, one of them was a cancer. I forgot what the other 2 were, but one was a serious kind of kidney disease. These were all deaths due to other diseases with kids that happened to have coronavirus. But now, with continuing experience and growing experience, we're beginning to see a condition in children. And guess what? Involving inflammation. No big surprise. We'll talk about that later. We've had a couple of questions about sunlight killing the virus, and a lot of statements about, yes, sunlight does kill the virus. So is there a practical use there? Another one coming up is death certificates. You know, we've had that recurring debate about the CDC and the feds and other people that are being labeled as bad guys are giving poor guidance in this area. They're saying they're telling hospitals label everything as COVID-19. I'm not, as you can tell from my comments, I'm not quite the critic in that space about that issue. I've made a living out of reviewing public health data. And I can tell you, you have to look at every piece of data that you get and understand that no piece of data is correct. But that's more of a 30,000 foot. This gets a little bit deeper into the details on, you know, one of the things that people don't understand is that only 1 in 3 death certificate diagnoses were correct before the whole coronavirus thing started. It's just going to get worse. And we'll go into some detail on that. I will also tell you one other comment. Given what most of you know that review this channel, you may not be surprised to find that 1 in 3 is really it's really better than the actual situation, because so many things that are labeled as heart attack and stroke really should have been labeled as diabetes or prediabetes. In other words, the underlying cause, and they're not listed. So, previous topics, for those of you who have not seen them and may have an interest in them, coronavirus attacking the immune system like HIV, attacking the T cells. We covered that yesterday. Is it safe to eat takeout? Oh, in fact, that reminds me of the last upcoming topic that I jumped over. Someone asked, I think Joe Riley said, you know what, if you get takeout food and you microwave it, is that a good idea? Actually, we found an article. Janice's sister Pam, just incredible at finding really appropriate, really good stuff for discussion. Found an article on, is it safe to microwave your food? And if so, how can you do that? I think you'll find the bottom line is that yes, you can, but, and there's a big but there. So pardon the pun. Other topics we've covered, you know, the young, healthy Broadway actor that lost his leg due to clotting. Again, a lot of interest and discussion about how COVID-19 appears to cause significant clotting problems, even in otherwise healthy people. Not so much people, I mean, yes, people with pre-existing comorbidities and diseases, but risk factors, but also in otherwise healthy young people. Major strokes, not minor strokes, major strokes in 30-somethings. So big deal there, and we've covered that. You can find that on our channel if you're interested. We talked about pulse oximetry, a simple, easy test. I got one of these from Amazon. They're very easy to get now. They're a little bit more expensive than they were 6 months ago for obvious reasons. And for a while, it looked like you couldn't get them. Obviously, I haven't geared mine up yet, but we'll give you the whole story behind pulse oximetry and some of the debate about whether or not you should have one around. So without covering other items, we'll go into, actually, I want to cover one thing. I asked Chris if he could develop a quick slide on this. A lot of press right now regarding Tony Fauci's announcement about Remdesivir. Now, Remdesivir it's an antiviral drug. It was developed, I'm pretty sure, for HIV, and I don't think it's actually been used significantly yet. But there's been continued excitement and interest about it. A day or two ago, I think it was 2 days ago, maybe 3, Tony Fauci came out and said, I haven't been so excited about a treatment since, what was it? One of the treatments for HIV. And people were looking at it, looking at the numbers and saying, well, why is he so excited? Because it's clearly not a cure. It's not a cure. There's no question. But it is, at least the numbers that we're seeing right now for Remdesivir are about the best that we've seen for any kind of treatment for the serious disease, COVID-19. So what you saw was a 31% improvement in timing to get out. So people get out. So here's what I mean. If you went into ICU, you are typically going to stay in the hospital for 15 days. With Remdesivir, you are routinely staying more like 11. So that's a big deal. It's not a cure, but it's a big deal. In addition, did it have an impact on mortality rate? Also the same kind of impact, about a 30%. So the mortality rate without the Remdesivir, with the placebo, was about 12%, 11.6% to be more exact. Those of you that are interested in that. And the mortality rate was 8% with the Remdesivir. So you see, you get about a 30% improvement in both length of stay in the hospital and mortality rates. So that's nothing to sneeze at. Again, pardon the pun. Another wave of COVID-19 outbreaks, experimental COVID things. We're going to be covering, again, some other items a little bit later. Some quick final announcements before we get to the feature. Again, as we've shared before multiple times, my time is getting more and more taken up with development of return to work programs for large employers and hundreds of thousands of employees, developing more of the systems, developing relationships with universities like Hopkins and Harvard, getting the proper review for these return to work systems, getting we've got one of the best virologists, laboratory virologists in the country involved in working on the testing itself. And by the way, let me just make a comment. Major improvements in the near future. I don't know if it's going to be 2 weeks or 4 weeks, but major improvements coming up with the antibody test. There are already places, some of the research institutions that have significant improvement in that antibody test. Anyhow, another bunny hole. The point behind this one was, if you're struggling to find a doc, you can still get you can get in our schedule and come see me. We will, I'm committed to helping out in that area. For those of you who are wanting to know, well, do I have risk? Am I one of those 90% of folks who have prediabetes and don't know it? How can I find that out? Because again, it's been documented. Most primary care docs do not understand this level of this problem. And we can show you some of the research if you have an interest. There's a way to do that, and it's very affordable, a few $100, less than 200 or less than 400. I mean, less than 500 if you want to get the tests as well included in it. So again, we've got that available. If you've got a CIMT, IMT, the ultrasound study of the neck using software to look at the amount of plaque that you have, which is far better than a stress test, by the way. A lot of people have those, but they don't have the they don't know how to interpret it, and their doctor doesn't know how to interpret it. We've got a webinar to help you with that. And finally, as I mentioned, stress test is not a great way to predict heart attack. Take it from Tim Russert, take it from a whole bunch of other people. A negative stress test does not rule out a heart attack. We got an upcoming book on that. I'll try to keep you posted. Okay, so thank you for your patience in waiting through all of those announcements and a couple of bunny holes. We'll get back to testing, where the testing is being done appropriately, right after the water ball. Carl. So, which tests are doing, which states are doing enough testing, not which tests are doing anyway. There's some activity in terms of settling that debate. And first of all, you got to ask the question of why does that matter? Well, again, we're in the midst of a pandemic. We don't even have testing to know who's got the virus. We don't have adequate numbers of that yet. The standard for public health is when you have an epidemic like this of an infectious disease, first find the cases and then do case management, contact tracing, find out who the cases have been in contact with, who else may have the disease, and then go from there. That's a basic, ages-old public health tool. I remember one of my, back in the 80s, 70s, one of my family members was a public health venereal disease investigator. And that's nothing but case finding and case tracing. Find out, it was syphilis back in those days, and find out who's got syphilis, and then go interview that person, find out who they've had contact with. Because if you don't, when you do that, you're saving the lives of people that have had infection and don't know it, and saving multiple other lives. So we've got a pandemic, and it's spread much more easily. We don't know who's got the infection. Well, obviously, that is a major problem in terms of a country who's had large number of deaths already, and wanting to avoid further crashing in our economy, wanting to get out there, restart the economy, but not knowing who's infected. So how much testing is enough? No exact number to aim for, but here's, WHO. A lot of people love to hate on them too. But the benchmark that they've put out there is that the percent of tests coming back as positive should be 10% or lower. And guess what? WHO is not, just like several other things, like their standards for getting back out there, the 6 conditions, they're not that far off from other folks either. Why should the positive tests be low? Well, if a high percentage of tests come back positive, it means there's not enough testing to capture all the infected people. If you look at South Korea, 2%, that meets the benchmark for sure. Germany, 7%, that meets the benchmark. And the US right now is around 20%, one of the highest globally. So is it a great idea for us to be opening up so many states and getting back out there? Well, here's the problem. If we're assuming that this high number means that we're going to be having a huge resurgence of the disease, maybe not so fast, because again, just like we've said multiple times, you got to look at what went into that 20%, and look at what went into the 2% with Korea and what went into the 7% with Germany. So when you see that in the US, our rates are 20% positive overall and higher in some places, it does clearly mean at least this: we're not doing enough testing. I don't think that the prevalence in the US is 20%. In fact, if I was, pardon another bunny hole. I've had 3 people send me the that hour-long press release from a couple of docs. They own an urgent care center in California. One of them is Masihi, and I can't remember the other one. And they made a strong case at one point that it was 6% prevalence in their county, and another point, I think 12%. There were a lot of things that were just dangerous about the assumptions that they were making. I'm not saying we don't need to get back out to work. Again, I'm spending over half my time getting us back out to work. But we need to be a little bit smarter in terms of how we look at our data. So back to the slide, back to the script here. When you see the U.S. rates are 20% overall, positive and higher in some places, it means we're not doing enough testing. Yes. In other words, she's not saying, this is Dr. Caitlin Rivers, an epidemiologist at the Center for Health Security at Hopkins. And she's not saying that she thinks that our U.S. Positivity rate is over 20%. I don't think so either. I haven't seen anybody make that kind of assumption. What that means is, in looking at the data, you see right now we're only testing people that have a whole lot of really good reason to be positive. So among the US states, the picture is mixed. Massachusetts, 23%, New York, 34%, New Jersey, 48%, Pennsylvania, 21%, Michigan, 23%. And so you go right down through there and you see a lot of states over 20%. Other states are reporting lower rates. Ohio at 14%, South Carolina at 11%, Florida at 9%, and Rhode Island at 14%. Now, of course, even if a state currently shows a low percentage of positives, infections could still surge in places where testing has been inadequate. Again, this is not so much about trying to figure out what is the, quote, general prevalence in that space. In fact, I can tell you from let me just say this. It's not finding and trying to develop an estimate of what the general prevalence is. It's knowing who you're testing, how many you're testing, and knowing specifically we've got enough tests and enough testing capacity to start finding outbreaks when they occur before they get out of hand and start developing a circle around those outbreaks and doing the outbreak investigation. And again, when you're seeing those high numbers, you're only doing a few very high risk, very likely to be positive cases. Let me just go down a quick bunny hole here. So I've dealt with this issue of what's the true population in the, quote, normal US population. I went through that whole exercise multiple times with HIV. I did a lot of public health work with prisons and jails in HIV, seroepidemia, in HIV rates. In fact, I developed a system for the Centers for Disease Control to look at the prevalence of infection, or the infection rates in people coming into jails and into prisons throughout the country. That's a big deal because the use of intravenous drugs prior to going into prison was up around in the mid 20%. In other words, about 1 in 4 people 1 in 4 men coming into prison had used IV drugs. After having been in prison, the rates of sexual activity, homosexual activity, went up to significantly over 20%. So that was a critical population to be looking for HIV. But then you start looking and saying, well, that's clearly not the, quote, normal US population. So the CDC had already set up things like your people coming into the ER. And then maybe another one with, well, what about churches? Well, what about colleges? As you begin to look at each one of these places where we collect disease rates, you begin to realize that, well, especially for something like HIV, collecting it at church you're not going to get the same population that you get coming into prison. Even coming into prison, you're going to get a different population from people coming out of prison because of the increased homosexual activity. People in the ER, well, could you say that ER is more of a general look at the U.S. population? Kids don't go into the ER very much. At least, it depends on which ER you're talking about. Some of the inner city ERs with the Friday and Saturday night trauma, yeah, you're going to see younger people in there. But again, as you begin to see, I hope I'm beginning to build a case around there is no such thing as a collection site that's going to get the quote average or normal U.S. population. In fact, there is no such thing as the quote average or normal U.S. population. You just can't get there. So let's go back to the script. As of April 25th, around 50% of states failed to meet the White House benchmark for relaxing the social distancing measures, according to analysis by U.S. News. They were using University of Missouri data, which again, you got to look and see what went into the assumptions for their data. So this suggests that many cities and states may be poised to reopen prematurely, which may court a resurgence of coronavirus cases and deaths. And I do think there's a significant risk there. Again, I know that many people will see this as a political statement. In fact, one of the people that sent me this this statement from these urgent care docs in California is a good friend, and he and I are having some significant friction over this issue. It's like, maybe you're one of these harebrained public health people that you don't understand what devastation a bad economy creates. Let me push back on that. I got halfway through an MBA at NYU. This was after my physician's degree, after I'd actually started the work world. I ended up having to move to Nashville and that's why I wasn't able to finish it. But to me, the economy is very important. If you look overall globally, the public health statement that a rising tide raises all ships, I think is still one of the most important public health statements. And what does that mean? It means if you improve the economy, you're going to be able to deal with all of the other issues, determinants of health. I still believe that. I used to get laughed at Hopkins when I was training in public health and faculty there because of my dogged push in that area about it's the economy. But even though I would say, yes, it's the economy, even though I come from that perspective, I think a lot of states are probably going too early. And if I'm right, what we'll see is we'll get a big increase. The culture will not be able to take the increase in deaths, and then we'll have to back up again a little bit. But we will get through that. Carl, we had a video today, a video clip, this one, right?
Yes, Doc, we have.
You want to go ahead and show that?
Okay.
And before you do, I'll just make the comment again. It's like anybody that's in a position of authority and responsibility, folks love to hate on. And Tony Fauci has no paucity, no dearth, no lack of Tony Fauci haters. But he's got some good comments in here, and let's go ahead and roll that, Carl.
Anthony Fauci, the administration's top infectious diseases expert, said Thursday that the United States needs to, quote, significantly ramp up its testing capacity in order to effectively contain the coronavirus as blunt measures like stay-at-home orders are eased. Fauci said in an interview with Time magazine, quote, I agree you don't need to test everybody, but you should at least be able to test the people in which you have to test to be able to do containment. I mean, on paper, it might look okay, but we absolutely need to significantly ramp up not only the number of tests, but the capacity to actually perform them. He noted there are problems with securing supplies needed to conduct the tests as well, such as swabs and chemicals.
if, as we open up the country economically and otherwise, if we have the capability to implement well when new cases occur, which they will, there's no doubt that they will, as you try and relax mitigation, if we have the capability of identifying, isolating, and contact tracing in a highly effective and efficient way, then the numbers will stay low. It may be 80,000, whatever, 70,000, like the model says. If we are unsuccessful or prematurely try to open up and we have additional outbreaks that are out of control, it could be much more than that. It could be a rebound to get us right back in the same boat that we were in a few weeks ago. So that's why we've really got to be careful and very circumspect as we go from a lockdown to a gradual rolling re-entry into some sort of normality. So it's not going to disappear from the planet, which means as we get into next season, in my mind, it's inevitable that we will have a return of the virus, or maybe it never even went away. When it does, how we handle it will determine our fate. If by that time we have put into place all of the countermeasures that you need to address this, we should do reasonably well. If we don't do that successfully, we could be in for a bad fall and a bad winter.
So thank you, Carl. As again, James Cantor said the other day, gave us some critical feedback, said, I can't tell when you're making the transitions. That's understandable, especially when you go down as many bunny holes as I go down. But thank you, Carl, for setting up that clear transition. Now we're going into Q&A. First one, perfect start from Joe Riley, plus a super chat button, $5. Thank you so much, Joe. I appreciate that. And yep, I think most of that start was Carl and his technology. I couldn't believe he set up that little timer. Speaking of super chats, David Ferguson, thank you so much. $20. You're amazingly helpful, knowledgeable, tactful, and diplomatic. Keep up the good work. Your COVID-19 videos are better than we get from Trump and Pence. Science, not moron. Well, anyway, I'll just leave it as thank you very much, both for the contribution and for the compliment. Jim Hyde, are you licensed in Florida? Yes, I am, Jim. In fact, I'm licensed in about 40-something states now. I think I started to say I think one of them that I'm not licensed in is Wyoming, but I'm not even sure at this point. Michelle can tell you. The bottom line is the big states, Texas, California, Florida, New York. I used to live in New York, so I got that whole region there. And again, there's only a few states that I don't have covered. And if you're asking because of patients, I do have patients, for example, all over the world. I've got patients in Brazil, the Middle East, England and Europe, Australia, lots of places. Very interesting group of people. Lori Latowa at Jim Hyde. Yes, Dr. Bro, thank you, Lori. Robert Simpson, I heard the hospitals get more money if they put COVID-19. I've heard people comment on that. I can't confirm either way, but I am absolutely sure that there's a lot of hospital administrators that are figuring that, even if it's not clear or even implied at this point. They're probably figuring, you know what, there's a lot of federal aid money coming out related to that. Joe Riley, 96%, 77 BPM. What does that mean? He's talking about his pulse oximetry. He's checking his pulse ox. And in fact, Joe was the one that suggested we cover pulse oximetry. Thank you, Joe. It was a great topic. How soon in the infectious process can Remdesivir be used? I think that's a good question. I think it's a long haul before you see it being used like, I mean, Remdesivir does have some things similar to the to other antiviral drugs. Somebody help me, I'm blanking on the name of Tamiflu, for example. Tamiflu decreases the extent of the duration of the disease and the virulence of the disease, how serious it gets. I believe Remdesivir is similar in having those two types of impacts. So the next very obvious question Joe nailed, and that is, when can the rest of us have it? When can we start getting it as soon as we find out what's going on? I mean, that we have this infection. I don't know, but that doesn't mean I won't give you a guess. My guess is I don't think it'll be ready for that kind of prime time even by the fall. I mean, this is getting that kind of, millions of dose availability. That's going to be a long haul. Jerry West, again, thank you so much, guys, for the super chats, the donations. As you've noticed, or maybe you haven't, some of our folks are here in the U.S., some of them are in the Philippines, and the folks in the Philippines are in a totally different economy. $20, even $5 makes a huge difference in terms of our ability to get this message out. As I've mentioned before, I've financed this activity mostly through my other work. After my third retirement, I didn't have other work other than I was always doing some consulting and some other things, but did not want to burn, and promised Janice that I wouldn't burn much of our retirement money on this. So again, it makes a huge difference to see folks make a contribution like that. Thank you so much. TW Wright, good morning, Doc. Good morning to you, TW. Robert Simpson, what about these at-home testing kits that are about to come out? They say these tests are $119. That's crazy. Insurance should cover this. Well, insurance should cover this. And Robert, you're bringing up an issue that I am eyeball deep in. And I mentioned it earlier, and because you bring it up, I'm gonna go there again. It's the antibody test. If this were a simple world, then there would be a $20 antibody test, or I don't know what a home pregnancy test is. What is it now? 30, 50, 20, I don't know, $100. If you had that, it would be a huge thing, right? There are two major problems with that concept. The first one is there are a lot of tests out there that aren't so good. The second is it's a difficult concept. I'll probably stumble around it a little bit. It's something that confuses every public health epidemiology student coming out of the blogs. And that's the fact that depending on the prevalence of disease in a population, the actual false positive rate and false negative rate, here, we're mostly worried about a false, well, we're worried about both, false positive and false negative. But let's talk about false positive, because here's the thing. Everybody wants to say, okay, I want to get back out. I want to make sure that I'm immune before I go, or at least I would love to be immune, and that would make me feel comfortable if I go back out. Well, you get an antibody, you go to the store, you get a $119 antibody test, and it's positive. Hallelujah. I've got the antibody. I'm immune. It's not going to hurt me if somebody sneezes in my face. Not so fast. Let's just look at the possibility that that could be a false positive antibody test. Let's say Here's where I'm going to stumble over the numbers, but as I stumble around them, I think you'll start to get the point. Let's say it's like a 95% sensitivity and specificity. Those two things mean something different, but let's just say this. Well, you know what? Rather than get too deep into this, let me just leave it at this. In a low prevalence group, a screening test like this, even a good screening test, if you get a positive, it's as likely to be a false positive as it is a true positive. That's just the way it is. Now, if 50% of us were already infected, then the probability that that antibody is truly there is much higher. But by that time, the antibody test almost doesn't matter as much because at that point, we're starting to develop true herd immunity. So again, you know, I keep thinking maybe I should study and figure out a way to talk about that. I do have a video on the difference in predictive values of tests, screening tests. It wasn't that well viewed anyway, so I think you may be able to see why. That's a murky issue, but it's true. In a low prevalence population, a positive antibody test it leaves you asking the question, am I feeling lucky? Do I really want to go out there? And some people will, you know, some people will have to. These are very difficult times. Jackie Shaheen, another $20. Thank you so much, folks. I really appreciate your contribution to the effort to get this information out. I know heaven already has a space for you. Thank you so much, but don't leave anytime soon. Well, I plan on not doing that. And in fact, I think I was talking with somebody yesterday about this. Barring, you know, a COVID-19 bad experience or a bus or a cancer, I expect to be around about another 30 years. I'm only 62. Robert Simpson, what about these at-home test kits? Wait a minute. We're starting to bounce. This thing's starting to bounce around again. Jerry West, any recommendation yet on the best serology test? Well, that's just what we're talking about. Actually, no, Jerry. It's a great question. I can tell you, I was on the phone again quite a few times over the past week with some folks at some of the top research institutions, and there are two major developments about to happen with antibody tests. Now, I say about to happen, you know what happens when you say that. It's about to happen and then something blows up. But let me tell you what the two major activities are right now. And both of them, the tests are already being tested, being trialed. There are tests right now which create a score. They look at the amount of antibody that you have, not just yes, they have antibody or no, they don't. That then, assuming that concept works, then you'd be able to get not only just a yes or no, but you'd get a screen on how much antibody does this person have, and even a score of 1 to 5. That's the way that's being developed right now. Obviously, that sounds like a lot better than an at-home pregnancy test kind of model. The other one is looking at the different types of antibody, IgA, IgM, and IgG. If you haven't heard of those, maybe the best way to say that is with both, Carl, Joe's telling us there's no sound.
Yeah, I've already confirmed with Lori. We are good to go.
Okay, thank you. Thank you, Joe. Where was it? Okay, so there are multiple types of antibody. There's IgE, and Ig stands for immunoglobulin. Immune, globulin meaning protein. So it's the antibodies. IgG, well, which is the permanent, most effective antibody. IgM, which starts, and IgG usually starts at about 3 weeks of infection. IgM usually starts at about 2 weeks of infection. It's very different. It's got 5 components to it as opposed to the one with the IgG. That starts at about 2 weeks, and it's not nearly as effective as IgG, and it's clearly not as long lasting. And then there's IgA, which comes out even before that. So you've got these, you've got a scenario where it tells you, again, not only is there antibody, but what kind of antibody, A, M, or G. And then you've got this other competing kind of test, which is looking at the amount of antibody. Again, both of these are already being used in research settings. So that's why I'm saying they're coming out soon, assuming everything works. And I would love to be in a position 2 weeks, or probably more likely at least a month from now, where you've got those 2 antibody test scenarios available and competing with each other. Robert Simpson, at this one prison, I heard 80% of the inmates have tested positive for COVID. Yeah, I saw a lot of interesting stuff. When I was doing that work with the prisons, huge amounts of intravenous drug use and homosexual activity once you got into the prison. But the interesting thing that we found was that at that point, at least, relatively little transmission of HIV. And we could go into details, but again, that's an old bunny hole, not a new one. I think the new one is, you know, do you have conditions for things like this to spread? Obviously, if you've got conditions where you have sexual activity, you clearly have conditions where you spread something like COVID. There's just no question in my mind. That's a significant issue. And these people that are talking about being in prison is you've got a significant risk there. There's no question, you do. Richard Lyon, another issue with our sheltering is the hole in our hearts from lack of human contact. My mother's not seen her husband in nursing home for 7 weeks. She's been isolated all winter. You bring up a good point, Richard. A lot of people, and my first reaction, when, you know, Janice will say this, and my first reaction is, well, yeah, but, you know, I'm in front of people's faces all day, every day. I'm on Zoom probably at least 5 hours a day, Zoom or StreamYard. But as you point out, you know, that's not always an option. For example, with Janice, they've actually put her on with her mother, who's in a nursing home, several times, even with Skype. But it's not easy. It's just not easy. There is no replacement, and there is no complete replacement for human-to-human interaction. David Ferguson, if both PCR and antibody tests for COVID-19 were readily available for everyone, would you get tested? How often? Assume cost of the test about $100. Yeah, of course I would get tested. Again, see, I'm probably not a great person to ask for that, because I used to travel my whole life. I would be in my home office, for example, when we were in Nashville, I was in my home office in Nashville 3 days a month. 3 days a month. It was like a traveling salesman, because I was providing medical direction to companies as wide-ranging as Google, Goldman Sachs, Toyota, you name it. I mean, we'd had, gosh, how many hundreds of clients did we have? I was not the only doc. We had about 700 docs, but still, it takes a lot of work to fit a doctor's mindset into a corporate and production type of mindset. And that's what I did for years. Then I had a major need to be traveling in airports and in front of people. Now, like I said, I'm doing almost everything over the internet, either Zoom or this kind of broadcast. So I don't have nearly as much need. Now, maybe some of that discussion, David, is helping answer the question anyway, because here's the thing. It really depends on your need. One of the groups that we're working with it's a consulting group. They have consultants all over the country, and they're not just consulting like me where the knowledge is already there. They have to go out and look at specific equipment. They cannot just give an opinion until they do some hands-on activity with equipment. Well, obviously, then that means they need to travel, which means they need to go through an airport, which means, yes, these people are going to be getting tested early and often. And that's exactly, some of the activities that we're going through in terms of helping these people figure out how to get back into the workspace. Chuck K, does contact tracing make anyone else nervous? I don't mean to laugh. Actually, if you look at China, already huge privacy abuses because they've done, that's just the Chinese government. We blame it on the communists, but that was happening long before the communists came in. Chinese government, even back with the first dynasties, they considered themselves as owning their people, not the other way around. And if you look at some of the software now, for example, the Chinese government developed and driven software for contact tracing already. And Carl maybe mentioned that to Chris. I thought I sent an article to him on that where it showed a picture of someone getting ready to get on the subway. And he had his cell phone and he was looking at he was taking a QR code. Well, the QR code was linked to the Chinese contact tracing software. In other words, the Chinese government had it geared up to where if you had evidence of having infection, you couldn't get on the subway. Now, you might say, Chuck, that that's a major invasion of privacy. Others might say that's only being safe. Major debate's going to come out of that. And I've already heard, Janice was telling me a few days ago about somewhere in the US where they were starting to look at posting information on who's infected. And I will also tell you this, there's already stuff going out with child molesters that's already put out there. And you can say, well, if somebody's been convicted of child molestation, they don't own their privacy anymore. I think our society's already spoken on that debate, but even though there's still debate around it, but we still haven't debated our way through what's appropriate for contact tracing and privacy and what isn't. You're right. That's going to be a major set of issues. Richard Lund, Gilead said next year on Remdesivir, they have donated their existing stock to the US or to us. I hope you can't hear that lawnmower out there. If you can, sorry, I don't have an option of changing that at this point. James Cantor, thank you. Share that testing should be at least 10 times the number of positive cases. Not sure exactly how you're set up on that, but yes, you're right. The standards that they're recommending, I think, make sense. And you can debate different scenarios that would monkey with those numbers, but the bottom line is they overall make sense. We do need to have a low enough rate to indicate, A, we've got testing available, and B, we're able to deploy it, and C, the infection rates are not out of control. That's what these low infection rates demonstrate. You got a 30% positive rate. One of those three things is out of control, and maybe all three. Bart Robinson, I agree. Thanks for joining us, Bart. Good to hear from you. And then we get into the no sound issue. I'm so sorry about that. I don't know how long that was going on. Robert Simpson, there's no way you can practice social distancing in prisons. Exactly. Karsten Nielsen, do people with enlarged heart have increased risk for complications? Any of the cardiovascular diseases, and that would be one of them. Progressive, super sticker. Thank you so much. Again, we really appreciate the contributions. They help us get this message out there. I don't see other comments. Gosh, it seems like it's only been half an hour. I guess I don't get too tired of hearing myself talk. Thank you so much for your interest, folks, and we will see you tomorrow.